Hello guys, this is Dr. Asif Nawaz. After a long time, I just came back from my very busy schedule of the surgical residency. Now I'm going to start the rest of the anatomy session, that is head neck. So let's start. That you all know that I have made a playlist about MRCS study with me. So please follow me. Okay. First, that is the foramen of base of the skull. Okay. So there is a mnemonic about oval. Okay, OVLE. O, that is optic ganglion. So you must know very clearly about what are the structures go through the foramen of the base of the skull. So that is the sphenoid bone and the foramen on oval present in the sphenoid bone. Okay, so let me just, okay, this is sphenoid bone and the foramen oval. Okay, so what are the structures? So that is otic ganglion, mandibular nerve, third branch of trigeminal nerve, that is mandibular nerve, mandibular division of trigeminal nerve, an accessory meningeal artery, laser petrosal nerve, and imagery vein. And which is important of among them? That is mandibular nerve, that is third branch of trigeminal nerve. Now the foramen spinosum, it is also present in the sphenoid bone, and middle meningeal artery is the main branch. So what is the foramen of rotundum and the lacerum? So you must know the three important foramens, that is foramen oval, rotundum, lacerum, and jugular foramen. So these four foramens is very important for MRCS Part A exam. That is sphenoid bone, that is maxillary nerve, that is second part, third branch goes through the foramen oval, and the rotundum causes maxillary division of trigeminal nerve, and the lacerum is internal carotid artery. Okay, just remember that very clearly. Jugular foramen, so there are three structures: anteriorly inferior petrosal nerve, intermediate glossopharyngeal vagus and accessory nerve 9, 10, 11, and the posteriorly sigmoid sinus becoming internal jugular vein, some meningeal branch. So you must know these things. And then the foramen magnum, that is occipital bone and anterior and posterior spinal artery. Okay, foramen magnum is very important because it is very great opening, because it contains spinal cord along with some spinal vessels, that is anterior and posterior spinal arteries, vertebral arteries, and medulla oblongata, that is brainstem. Now this stylomastoid foramen, it plays in here because it is very important for because facial nerve that comes through the extracranial region by this foramen, because it is also a part of cranial, that is brainstem. Temporal bone, its stylomastoid foramen is present in the temporal bone actually. So stylomastoid artery and the facial nerve. Facial nerve is very important because you have to remember where the facial nerve come from, or the single branch comes through the styloid foramen, and then it divides into 5 different branches, gives supply to the facial region, that is motor supply to the facial region. Now the superior orbital fissure, it is also present in the spinal bone. There are a lot of structures here. One is lacrimal branch of ophthalmic nerve, and the frontal branch of the ophthalmic nerve, and the recurrent meningeal artery, trochlear artery, superior division of the oculomotor, and the superior ophthalmic vein. Abducens nerve, nasociliary branch of ophthalmic nerve, and the inferior division of the oculomotor nerve. So live frankly to see absolutely no insult. Okay, 4, 3, 4, 5, 6 and SR, that is lacrimal, lacrimal gland supplied by the ophthalmic nerve, and the frontal branch of the ophthalmic nerve, lacrimal, frontal, and the recurrent laryngeal artery. Trochlear nerve. So ophthalmic nerve, trochlear nerve, abducens nerve, nasociliary ophthalmic nerve, and oculomotor nerve. So these are the three important nerves, 3, 4, 5. So you must remember these things very clearly. So these are the foramens. So you must know the foramens very clearly, because it's not only important for MBBS reason but also the post graduation at least. So these are the foramens. So it's the picture of gray student copy. Also it will be found in the Natter, Frank H. Natter. Now the visual field defect. So this is three things. This is a box. What kind of visual field defect present here? That is homonymous hemianopia, homonymous quadranopia, bitemporal hemianopia. So here in short, monoocular vision loss, that is optic nerve lesion, bitemporal hemianopia, that is optic chiasma lesion. Here very important, optic chiasma, that is if you see here, this is optic chiasma. So if there is a lesion, that bitemporal hemianopia, because these temporal are here also crossing bitemporal vision. So this is a temporal, this is a temporal. So these two are crossing here. Okay, that is temporal from left side, temporal from the right side. These two are cross section here. So if there is a lesion, then two temporal region will be lost. Okay, that is bitemporal hemianopia. Okay, these two things, temporal region is lost. These are nasal and temporal. So upper quadrant defect is more than lower quadrant defect in inferior chiasma compression, complete pituitary tumor, and then if the lower quadrant defect is more than the upper quadrant, then superior chiasma compression, that is craniopharyngioma, that is Rathke's pouch. So Rathke's pouch present, that is a pituitary tumor. So inferior lower quadrant defect is more, but in case of common pituitary tumor, that is upper quadrant tumor is more. Homonymous hemianopia, that is optic tract lesion, and upper, that is temporal lobe lesion, and lower quadrant means the parietal lobe lesion. Okay, parietal. So these two things you must know, that if upper quadrant means quadrant of a temporal lobe, and the lower quadranopia means the parietal lobe lesion. Okay, very common, very small things. Just you must remember this important relationship here. Now the cranial venous sinuses. So venous sinuses, there's some are paired and unpaired venous sinuses. So it is within the dura mater. Okay, they have no valves. These sinuses has no valves. Important in potential for spreading sepsis, as there is no valve, so infection can be spread to the intracranial by these sinuses. They will eventually drain the jugular vein. They all drain into the jugular vein. So what are the names? Superior sagittal, inferior sagittal, straight, transverse, sigmoid sinus, occipital, and cavernous. These naming is important but not so important. Okay, just you must know what are the paired and unpaired. It can be asked in our daily fellowship exams in Asian region, but not been asked for MRCS. So cavernous sinus. So cavernous sinus is very important because there are some great vessels and nerves passing through this, and the important sign of entry of sepsis of intracranial to extracranial. So here the lateral wall composed of oculomotor nerve, trochlear nerve, ophthalmic nerve, and maxillary nerve. See, OTOM, O tomcat, O oculomotor nerve, T trochlear nerve, and O ophthalmic nerve, and the maxillary nerve, V1 and V2. and the content of sinus, that is internal carotid artery and the abducens nerve. Okay, so oculomotor trochlear, trigeminal, part of trigeminal V1 and V2, and abducens. So what it says, cavernous sinus syndrome is most commonly caused by cavernous sinus tumor. Diagnosis based on cause pain, ophthalmoplegia, proptosis, trigeminal nerve lesions, and Horner's syndrome. Okay, so these yellow color are the nerves, and this is internal carotid artery. So these full things is cavernous sinus. So this is the surrounding area, cavernous sinus. Okay, so it is connected with the basilar venous plexus and the circular venous plexus as well. Now important two, that is sternocleidomastoid. Here are the prominent muscles. It is called the sternocleidomastoid. One part is attached with the mastoid antrum, another one is the clavicle. Okay, clavicle and the mastoid process of temporal bone. Innervation, that is which is supplied by mainly spinal part of the accessory nerve, which is anterior C2 and C3 proportion. Action, both noding movement, that is right and left noding movement, extent of the head and atlanto-occipital joints. So here this is atlanto-occipital joints movement, and the accessory muscles of respiration is also act as, and the lateral flexion of the neck, that is here flexion, and rotates the head, so face looks upwards and upwardly, that is like this, rotate the head side by side, and the noding movements. Okay, so this movement is done by sternocleidomastoid, which is supplied by the accessory spinal part of the accessory nerve. Okay, the motor supply of the sternocleidomastoid is from the accessory nerve. The ansa cervicalis supplies the sensory information from the muscle. So accessory nerve is the pure motor nerve. So what are the sensory portion, which is by the ansa cervicalis, and the sternocleidomastoid divides the anterior and posterior triangle of the neck, because you can see this is the anterior triangle and this is the posterior triangle. So it divides these two triangle. Okay, so this is the triangle, one anterior and posterior, which is surrounded and they divided by the sternocleidomastoid as well. Now the scalene muscles. So here you can see some little muscles, strap muscle present in the posterior area, what is called the scalene muscles, that is which insert in the first and second ribs, and this is three important paired muscles: scalenus anterior, scalenus medius, and the posterior. There is important relationship that in between anterior and medius, the brachial plexus goes through these two muscles, that is anterior and in medius. Okay, remember this very clearly. The brachial plexus and subclavian artery pass between anterior and medial scalenus. Okay, here it is. So scalene hiatus or fissure, it is called the scalene hiatus or fissure. In between two muscle, there is an area where the brachial plexus and subclavian artery goes through it. Subclavian vein and the phrenic nerve pass anteriorly to the anterior scalene as it crosses over the first rib. Let me see. Okay, sorry for that. So these are the strap muscles, like scalenis anterior, medius, and posterior. So in between two, subclavian artery goes through it. Okay, and the part of the brachial plexus as well. So thoracic outlet syndrome is a clinical condition where the scalenes are the risk of adhering to the fascia surrounding the brachial plexus, or shortening causes compression of the brachial plexus. Thoracic outlet syndrome means the brachial plexus will be compressed and it passes between the subclavicle and the first rib, closing outlet syndrome. So most probably cervical 8 and thoracic 1 plexus, that is lower trunk of the plexus, is entrapped in case of thoracic outlet syndrome. Okay, Just remember this very clearly, C8 and T1. Anterior triangle of the neck, you just know the contents of anterior triangle and the development as well. So here the anterior border of the sternocleidomastoid and the lower border of the mandible, that is mandible, anterior border of the sternocleidomastoid and the midline. So this area is called the anterior triangle. So it is divided by 3 subdivisions, that is submandibular triangle here, then muscular triangle here, and the carotid triangle. Submandibular, the carotid, and the muscular triangle. Okay, carotid triangle is closed by carotid sheath. Submandibular digastric tunnel. Now the digastric triangle, that is submandibular glands, nodes, and the facial vessels and hypoglossal nerve as well. So these are the structure present here. Just submandibular region. These gland, nodes, facial vessels here, facial vessels, and the hypoglossal nerve, which is motor supply to the tongue intrinsic muscle. Tongue, his movement of the tongue is done by the hypoglossal nerve, which is the motor supply of the tongue muscles. That is most probably intrinsic muscles. And the muscle triangle, that is strap muscle, external jugular vein, and the carotid triangle, that is carotid sheath, common carotid and vagus and carotid triangle. So carotid triangle is mainly carotid vessels, composed of carotid vessels and 2 nerves, that is vagus nerve and the glossopharyngeal nerve. The carotid sheath, commonly common carotid, vagus, and inferior internal jugular vein. So vagus goes in between 2 great vessels, common carotid and internal jugular, and the most superficially present, that is ansa cervicalis. Okay, so this is the 3 triangles: muscular, submandibular, and carotid region, and this is the posterior carotid. Now the posterior triangle of the neck, okay, very important. Sternocleidomastoid and trapezius muscle of the occipital bone, these 2, and the posterior and anterior border of the trapezius and posterior border of the sternocleidomastoid and middle third of the clavicle. So here you see, this is the posterior border, this is the anterior border, and this is the clavicle, this is triangle. Okay, vessels, external jugular vein, and the subclavian artery, third part, and the nerves, that is accessory nerve, obviously spinal accessory, and the phrenic nerve, and the 3 trunks of brachial plexus, and branches of the cervical plexus, that is supraclavicular nerve, transverse cervical nerve, greater auricular nerve, and the lesser occipital nerve. You must know that these things is not changing, because some portions you must read before exam, and which is not necessary in the part B exam, but you have to pass. In the previous exam pattern is changing. A lot of questions come from head neck, a lot of questions come from embryology, so you must go through these 2 or 3 extra topics from the textbook. If you have not so much time for that, you can go through these lectures as well. So it is absolutely free, so you guys can go through there for repeatedly watch the videos, so that you can have a proper knowledge, or absolute little but absolute knowledge from every steps of the video. Okay, so let's continue. So this is the internal jugular vein, and it has a 2 internal, external, and the brachial plexus and their branches, that is accessory nerve and greater and lesser occipital nerve, which is also present in the posterior triangle. Now the parotid gland. Okay, parotid gland, important gland, 2 pairs that lies posterior to the thyroid gland, and 4 located posterior to the thyroid gland and lies within the pretracheal fascia. It is very important. Parathyroid gland located where? It's called the pretracheal fascia. Embryology, very important. Parotid gland develop from where? Where these glands developed is very important. Parotid glands develop from extremity of the 3rd and 4th pharyngeal pouches. Okay, must remember 3rd and 4th pharyngeal pouches. The parotid derived from the 4th pharyngeal pouches are located more superficially associated with the thyroid gland. These derive from the 3rd thyroid pouches lie more inferiorly and may become associated with thymus. So third pharyngeal pouch, that is thymus, and the fourth pharyngeal pouch, that is along with thyroid gland. So parotid gland is upper half and lower half, upper pair and lower pair. Upper pair with the thyroid gland and lower pair with the thymus. So here's some derangement because lower pair of parathyroid gland is developed from the third pharyngeal pouch. It's like opposite, and the lower two are developed from the thyroid gland. Must know, it's must know. The blood supply of the parotid gland derived from the inferior superior thyroid arteries. Okay, blood supply of parotid gland derived from inferior and superior thyroid artery, that is thyrocervical trunk. Okay, thyrocervical trunk is the main source from where the inferior thyroid artery came from. And the superior thyroid artery is also from the thyrocervical trunk. There is a rich anastomosis between two vessels. So these two, superior and inferior, are anastomoting with each other. Laterally common carotid, and medially recurrent nerve and trachea, anteriorly thyroid, and the posteriorly pretracheal fascia. Okay. So these are the anastomoting with each other, and this is the thyrocervical trunk. So it gives supply to the thyrocervical trunk is the branch of subclavian artery. Okay, you must know that from where the thyrocervical trunk came from. It's called subclavian artery. Okay, so now the thyroid gland, the right and left lobes connected by the thymus. Okay, right and left lobe connected by the thymus. They are surrounded by the sheath from pretracheal layer of deep fascia. Surrounded by the sheath from pretracheal layer of deep fascia. So thyroid gland connected with or attached with the deep fascia. And the apex lamina of the thyroid cartilage base, that is 4th to 5th tracheal ring, 4th. And the pyramidal lobe, that is isthmus, pyramidal lobe present from isthmus, and may be attached with the okay, so anteromedially the sternothyroid and the superior belly of omohyoid, and the posteriorly the sternohyoid and antero aspect of the sternothyroid, sternocleidomastoid, and the posterolaterally, that is carotid sheet. So much posteriorly there was parathyroid gland and the anastomosis of the superior and inferior thyroid artery. So parathyroid gland lies posteriorly, and the superior and inferior thyroid arteries. Isthmus, that is anteriorly sternothyroid, sternohyoid, anterior and jugular veins, posteriorly 2nd, 3rd, 4th tracheal ring, attached by the ligamentum barri. Okay. And the arterial superior thyroid artery, first branch of the external carotid, and the inferior thyroid, that is thyrocervical trunk from subclavian first part. Thyroidea ema, that is 10% population from brachiocephalic artery or the aorta. And the venous, that is superior and middle thyroid veins into the internal jugular vein, and the inferior thyroid vein into the brachiocephalic veins. Venous, superior and middle thyroid vein into the inferior jugular vein, and the inferior thyroid vein into the brachiocephalic vein as well. So venous system is, that is our thyroid is supplied by the superior and middle thyroid vein, which is derived from internal jugular vein, and the inferior thyroid vein into the brachiocephalic vein. Inferior thyroid came from brachiocephalic vein. You must remember these three things is very important. Now the tongue. The lymphatic drainage of the anterior 2/3 of the tongue shows only minimal communications of lymphatics across the midline, so metastasis to the ipsilateral nodes is usual. The lymphatic drainage of the posterior third of the tongue have communicating network. As a result of bilateral nodal metastases are more common in this area. The lymphatic drainage of the posterior third of the tongue communicate with the bilateral nodal metastases. So posterior third of the tongue it drain in the nodal bilateral nodal metastasis most common area, and the tip of the tongue usually pass to submental nodes. So tip, any lesion from the tip goes to the submental region, and the mid portion of the tongue usually drain is submandibular. So mid portion from this true mandibular region and posterior of the deep cervical nodes. All the motor innervation provided the hypoglossal nerve except the palatoglossus, which is by vagus. So all the motor innervation, the motor supply of the tongue, that is the intrinsic muscle of the tongue, is supplied by the hypoglossal nerve except the palatoglossus muscle, which is provided by the vagus. And the posterior part of the root tongue is vagus, and the posterior 1/3 is a glossopharyngeal nerve, and the anterior 2/3 is a mandibular division of mandibular via lingual, and the antefacial chorda tympani. That is gustatory taste sensation and sensory innervation. Anterior 2/3 done by mandibular division of lingular nerve, mandibular via lingual, and the taste, that is most posteriorly facial nerve. And the posterior 1/3 is by the glossopharyngeal nerve, and posterior part of the root of the tongue, vagus. General sensation of the posterior third of the tongue contribute to the gag reflex. Okay, the general sensation to the posterior third, the general sensation to the posterior third of the tongue contributes to the gag reflex. Anterior 2/3, that is general sensation mandibular nerve, lingual nerve, and the special sensation to taste facial nerve via the chorda tympani of the facial nerves. And the posterior 1/3 is general and special taste, and the glossopharyngeal nerve, vagus. So let me see is very clearly. So this is very important. That is anterior 2/3 general and special sense. General sense lingual nerve, special sense chorda tympani, branch of facial nerve, and posterior, that is whole the glossopharyngeal nerve. Okay, and whole portion, that is both spatial and general sense, done by the facial nerve. Now the submandibular gland. Submandibular gland, the superficial platysma, submandibular lymph nodes, facial vein, and the mandibular marginal mandibular nerve. And deep, that is submandibular duct, hypoglossal muscle, lingual nerve, submandibular ganglion, and hypoglossal nerve. Submandibular duct, that is Wharton's duct, opens lateral to the inguinal frenulum to the anterior floor of the mouth, that is Wharton's duct. 5 cm length, and lingual nerve wraps around the Wharton's duct. The duct passes forward it and crosses medial to the nerve. It will lie above it, then crosses back. Innervation, sympathetic innervation derived from the superior cervical ganglion, and the parasympathetic innervation submandibular ganglion via the lingual nerve. So sympathetic innervation derived from superior cervical ganglion, and the parasympathetic innervation done by the submandibular ganglion via the lingual nerve. Okay, so parasympathetic innervation submandibular ganglion via lingual nerve, and the sympathetic innervation by the superior cervical ganglion. And the arterial branch of facial nerve. Facial artery passes through the gland of groove its deep surface. It then emerges into the face by passing between the gland and the mandible. Okay. A venous drainage, anterior facial vein, that is a branch of deep marginal mandibular nerve, lies deep to the, so marginal mandibular and the anterofacial vein, just superficial and deep, these two structure here. And the lymphatic drainage, that is deep cervical nodes and the jugular chain of nodes. The 3 cranial nerve, that is marginal mandibular ventrofacial nerve, lingual nerve, and hypoglossal nerve, lies just 3 that along or superficial to the submandibular gland here. These 3 important structure: marginal mandibular, frontofacial, then lingual nerve, and hypoglossal nerve. So hypoglossal nerve may result to paralysis of ipsilateral aspect of the tongue. Okay, the nerve itself deep to the capsule. So lingual nerve is probably greater risk injury. So effect on lingual nerve is sensory rather than motor. So you all know that general sensation of the anterior two-thirds of the tongue is done by the lingual nerve, okay, which is the part of the glossopharyngeal nerve. Here, the lingual nerve. In case of dental anesthesia, lingual nerve is usually blocked by injection. Now the parotid gland. So now the parotid gland. Parotid gland overlies the submandibular ramus and anterior inferior to the ear and the salivary duct. They cross the masseter piece of buccinator drain the second upper molar to the distension duct. Structure passes through the gland, that is facial nerve, the external carotid artery, retromandibular vein, and the auriculotemporal nerve. So auriculotemporal nerve, retromandibular vein, external carotid artery, facial nerve. What structure goes through the gland? That is facial nerve, external carotid artery, retromandibular vein, and auriculotemporal nerve. Okay, relations is the masseter, medial pterygoid, superficial temporal maxillary artery, facial nerve, and the stylomastoid mandibular ligament. Posterior belly of digastric muscle, sternocleidomastoid, stylohyoid, internal carotid, and the mastoid process of the styloid process. Okay. Artery supply, external carotid artery, both parotid gland, retromandibular vein lies, which gives supply to the venous drainage. Deep cervical nerve, parasympathetic secretomotor from otic ganglion, and sympathetic superior cervical ganglions, and sensory greater auricular nerve. Okay, very important, these kind of things. And the structures through the glands: facial nerve, superficial, deep retromandibular vein, external carotid artery, and auriculotemporal nerve from posterior trunk of V3. Okay, auriculotemporal nerve, retromandibular vein, external carotid artery. So here the 5 branches from just superficial to the parotid gland here. So that is all about our today's presentations. I hope you like the channels. I hope you like my videos. So it is the part 1, head neck, but in the next video I'm going to describe the part B. So thank you very much for watching, and keep watching the remaining videos, and it will give you a lot of help for the head for not only the MRCS but also in any other post graduation exam in the anatomy preparation. Thank you very much for patient sharing, and peace.